to welcome all of you for this CME on antimicrobial stewardship. It is a privilege to see such a diverse and dedicated group of healthcare professionals, including physicians, pharmacists, nurses, and students, all united by a common mission, which is the responsible and effective use of antimicrobial agents in our healthcare system. Today we stand at a critical juncture in the medical history. Antibiotics, once hailed as a miracle drug, is now facing threat of losing their power. Antimicrobial resistance is no longer a looming danger, it is a present day crisis. Every day across the globe, we encounter infections that are harder to treat, longer to cure, and deadlier to impact, all because of growing misuse and overuse of all these life-saving drugs. This CME has been organized not just to raise awareness but to empower action. Over the course of the program, we will explore practical strategies, evidence-based interventions, and collaborative approaches to antimicrobial stewardship. We will hear from experts who will guide us through the clinical, microbiological, and policy dimensions of the antimicrobial stewardship. We will also delve into real-world case studies and institutional practices, which will help you in showing the measurable success. Most importantly, we are here to reinforce a simple yet powerful message. Every prescription counts and every decision matters. Just to give you a little perspective about this CME flow, we have two panel discussions and multiple lectures by eminent faculty. We will be having a lamp lighting ceremony at around 11:15 a.m. and a lunch break at 1:30, which is again arranged at the backside of the auditorium. Faculty and chairperson will have a separate area for dining. As per MMC, a separate register is kept for marking your exit. So entry and exit both have to be marked. Please don't go without marking the exit part. Lastly, all of the delegates will receive a WhatsApp link which will lead you to a questionnaire which will have 18 questions related to antimicrobial stewardship. I request all of you to fill it up maybe by lunchtime, till lunchtime. So we will gather, we will see who has scored most, and we will have five lucky draws, and 5 people will get a book, which is the last one, clinical cases in critical care. So this book will be given to 5 delegates in the end, right? So lastly, I will start this CME by giving you a little perspective about the current scenario of antimicrobial resistance in India. So this is all Indian data, and then I'll ask my colleagues and the experts in the field to take you through the path of antimicrobial stewardship. Okay, so let me begin with the extent of problem of AMR in India. So this is all Indian data. So if you see, this shows the distribution of priority organisms as defined by ICMR, pathogen isolates in different locations. So if you see, the E. coli is commonest in inpatient and outpatient and emergency department, but in ICU, Klebsiella and Acidobacter are dominant species. This is for gram-positive cocci. So if you see, overall staph aureus is almost 12% of the isolates that are grown in the labs across the Indian ICUs. So in Western population, gram-positive infections range in around 50-55%, but in India, the incidence of gram-positive infections is much less. So only 12% have grown Staphylococcus aureus. Out of these, almost 50% to 55% are MRSA. Okay, so that becomes important. So probably around 6% are MRSA as compared to Western data, which is very, very high. Now this is resistance profile of staph in blood, which has been collected throughout the India. So if you see, the resistance to teicoplanin and linezolid is least. Now the proportion of ESBL, E. coli. So if you see, the ESBL producing E. coli has increased in last year. It has decreased from 2018 to 2022. Now again it has shown a rising trend. This is the resistance profile of E. coli in blood. You can see that even to meropenem, the resistance is almost to 40% in ICU, if you can see it here. And the susceptibility to colistin is very, very good. Similarly, resistance profile of Klebsiella, if you see in ICU, the sensitivity to colistin is still very, very preserved, but almost 50 to 60% of isolates are resistant to carbapenems, and this is all Indian data. Acinetobacter, third most important one. Again, the susceptibility to colistin is preserved, but the resistance to meropenem and imipenem is almost up to 70%. So almost 70% of isolates of Acinetobacter are resistant to carbapenems. Again, the resistance of carbapenem in Enterobacteriaceae. So if you see, E. coli almost 35%, Klebsiella very high, and other Enterobacteriaceae almost 40-45% are resistant to carbapenems. We know that ICUs, if we can say, epicenters of antimicrobial resistance because of risk factors, because of heavy use of antibiotics in ICUs, previous exposures to antibiotics, presence of invasive devices, immune suppression, malnutrition, all those factors contribute to resistance of development of drug resistant infections. So what is the solution? So solution is antimicrobial stewardship, prevention and control of nosocomial infection, which is the theme of today's CME. What is antimicrobial stewardship? It is a balance between appropriate initial antibiotics, which is obviously empirical, and avoiding the unnecessary antibiotic usage and unnecessary increasing the antimicrobial resistance and the cost. So that is the core of antimicrobial stewardship program. What are the goals? Goals are to combat antimicrobial resistance, to improve patient outcomes, to improve patient safety, and to reduce healthcare costs. Okay. So antimicrobial stewardship is a teamwork. A team should be prepared in all the hospitals, which should be inclusive of infectious disease physicians, clinical pharmacist, microbiologist, and a person dedicated to infection control practices. Thank you very much. I will hand it over to my colleagues, Dr. Nikhil and Dr. Mandeep. They will take you through the further CME program. Thank you.
Good morning, everyone. On behalf of Indian Society of Critical Care Medicine Mumbai branch and Terna Speciality Hospital and Research Center Mumbai, we welcome you all for the CME. I know it's a hot sunny morning, and we all are eagerly waiting to start our talk. So, me and Dr. Mandeep will be taking you through this course of today.
Good morning everyone. I, Dr. Mandeep Kaur from Critical Care Department at Terna Speciality Hospital would like to extend a special warm welcome to our faculty members. We are deeply grateful for the presence and the time you have taken out today. Your guidance will add a tremendous value to the discussion ahead. So thank you and welcome everyone.
So without much delay, it's time to begin our first section. And I first invite the chairperson for this first session. I'll invite Dr. Archana Matre ma'am. head and professor and head of Department of Anesthesia was here at Terna Medical College. Dr. Bharat Rawal sir is a leading physician and organ critical care expert in the city of Mumbai. Dr. Vinesh Srivastava, who is head and he is head of emergency department at Terna Medical College and Hospital, and Dr. Lakshya Sardar, who is head of pediatric critical care department at Terna Speciality Hospital.
So, in high stakes environment of the ICU, every decision counts, especially when it comes to antibiotics. This session on antibiotic stewardship using biomarker highlights an evidence-based approach that helps clinicians strike the right balance between timely intervention and responsible antibiotic use. We would like to invite our opening speaker for the day, Dr. Smriti Tiwari. She is a distinguished expert in anesthesia and critical care medicine with a keen interest in antimicrobial stewardship. Currently, she serves as an associate professor at Terna Medical College and a consultant in critical care medicine at Terna Speciality Hospital. She will be sharing her experience on antibiotic stewardship using biomarkers in the ICU, a topic that is highly relevant in optimizing antibiotic use in critical care settings.
Hello everyone. So sir has introduced about the antimicrobial stewardship program. What is the meaning of antimicrobial stewardship and what measures we should take to avoid this, because if resistance is not dealt with, we will have a very grave situation where patient will end up in high mortality in the sepsis in the ICU. So I will my topic is biomarkers in antimicrobial stewardship, optimizing ICU care. So antimicrobial stewardship is vital in ICU. So how biomarkers can guide the therapy that I will be explaining. So this presentation of mine covers current challenges and it also covers applications and future directions. I want to first start my talk with sepsis. So sepsis is the most common cause of mortality in ICU. So what is the current sepsis mortality factors? So delayed recognition. So every hour of delay in the diagnosis of sepsis increases the mortality by 7.6%. I think this is a very good study and everybody knows about this, that there is an increase in the mortality by 7.6% in every hour delay of sepsis diagnosis and treatment. Then pathogen identification. So limited rapid diagnostic tests are available to diagnose the sepsis and the organisms. Then antimicrobial selection. So today's talk will be elaborative to tell you about the various gram-positive infections, gram-negative infections, the fungal infections, how to treat them. But still we are still lagging behind in the selection of the therapy, and it doubles the mortality risk. Then healthcare infrastructure. Resource disparities impact the global survival rates. So even in resource limited settings like medical colleges, the resource disparities also impact the mortality. So all these factors increases the mortality in sepsis patient. So I will just tell in numbers how the sepsis is a global health crisis. Even more than the myocardial infarction, strokes, the sepsis has a global health crisis. 11 million people have been diagnosed as sepsis annually. Out of this, 20% mortality is there in the sepsis patients, and out of these, 35% deaths are in ICU. So we are every day seeing these patients dying of sepsis. So we have now turned a stone heart for this. And the most important thing is the annual cost. So it is a $24 billion cost of sepsis related mortality and ICU setting care. Can see the geographical variation. So sir has given the Indian numbers. So this is a global geographic variation in sepsis mortality. Can see the North America, Europe, South America, Africa, Southeast Asia and Asia Pacific all have those increased mortality rates. So sir has already focused the point of antimicrobial resistance. So what is the reason for this? Antimicrobial overuse, inappropriate prescribing drives resistant the development. Also global spread, the international travel also increases. So MRSA is not common in India, but if some patient comes from outside, he will travel with the MRSA. So the international travel also adds to this. Then genetic adaptation, bacterial mutations conferring the resistance, and hospital transmission. The resistant strains are proliferating from one hospital to other. When the patient is transferred from one hospital to other, the resistant strains are transferred. So we, whenever there is more than 48 hours of stay in ICU, we check for the MRSA. So 30% of sepsis cases have antimicrobial resistance. Sir has already focused this. 12% annual increase of the CRE patients, and 64% higher mortality in these patients. So out of this, MRSA and CRE are most common. So now focusing on my today's topic. So what are the traditional diagnostic methods which we know, which are routinely used in our ICU? So gold standard is blood culture. So whenever we have to decide about the pathogen, what antibiotic to be given, the gold standard is antimicrobial culture. But what is the time limit? It comes in 2 to 3 days. So it takes almost 3 days for diagnosis of the infection. So till that time, sometimes patient comes in septic shock. So it is very difficult for us to diagnose the sepsis and the organism, the culture taking 24 to 72 hours. Also, the patient has already received antibiotics in outside settings, the hospitals, the OPDs. So 30 to 40% have false negative rates. Also, it is limited by prior antibiotic exposure. And what are the conventional biomarkers? The WBC count, the sensitivity is only 83%. The CRP, the sensitivity is 67%, and lactate, it shows mortality predictor, which is also a very conventional marker, but is not specific. Then the clinical scoring systems, the SOFA scoring, the quick SOFA and the SIRS criteria, these are standardized assessment mode. So what are the limitations of traditional diagnostics? The results of, it takes 24 to 72 hours, delaying the targeted therapy. Then diagnostic accuracy, poor sensitivity specificity for early sepsis detection. Then culture negative sepsis in 30 to 40% of confirmed cases. So the culture is negative, but the patient is in septic shock. So how to diagnose those patients? Then susceptibility test. So this is additional test which we do to see for the susceptibility of antibiotics, means the MIC which we call. So it takes more 24 to 48 hours. So there is delay. So this algorithm, it shows that how it delays the antibiotic treatment and how the patient lands up into septic shock before any diagnosis is made. So today's topic now starts now. So what are the emerging biomarkers which we should use in our ICUs, which will help? So of this now currently being used as a FDA approval is procalcitonin. So it is a precursor of calcitonin hormone produced by multiple tissues during the bacterial infection. Level rises within 2 to 4 hours of infection. The sensitivity is 77 to 80%, specificity is 78 to 83%, and positive predictive value is 81%. So what does PCT do? It distinguishes bacterial infections from viral infections. So if there is PCT which is high value, so it will distinguish a bacterial infection. So we can rule out is a bacterial, viral versus fungal. Okay. Then it guides the antibiotic initiation and discontinuation and correlates with the infection severity. So if the PCT comes to our ICU patient comes and we do a PCT, and if the PCT is more than 100, so we know that this patient is very sick and the mortality rate of this patient is very high. So at least we can diagnose that how the prognosis is of the patient. Then this is a new biomarker. I think many of people sitting here must not be knowing about this biomarker. It is a presepsin. It is soluble CD14 subtype shed from monocytes during bacterial phagocytosis, it rises within 2 hours of infection. Now, even I have asked in my lab also, we are getting to do the preceptin to be done. It is not very costly, very less cost than the antimicrobial charge which will be there if the stay is prolonged. So, preceptin is available in our lab also. I have confirmed it. So, it is a CD14 subtype shed from monocytes during bacterial phagocytosis. It rises within 2 hours of infection. What is the diagnostic value? So diagnostic value is sensitivity is 86% of early sepsis and specificity is 78%, superior to PCT for early detection and correlates with the sepsis severity. Okay. Prognostic marker also, higher levels predict increased mortality and valuable for risk stratification, useful for tracking treatment response. First I am just telling about what is the marker and then I will be telling about the studies. Then this is a novel biomarker. This is a pancreatic stone protein. It origins and secreted by pancreatic acinar cells during stress. Its role is in cellular autophagy and inflammation regulation. It is less affected by comorbidities like PCT. So if there is a rearrange RFT, LFT, then PCT is altered. But pancreatic stone protein has less affected by the comorbidities. Sensitivity is 89% and specificity is 83%. And it rises early within 3 to 4 hours of the post-infection. Then this is a septicide. This is emerging biomarker, but it has not come in the Indian labs. But we should know about this. It is a 4-gene host response assay. It is similar to a RNA and DNA PCR which we are doing, but it is a single test. Okay, the detection rate is 89 to 95%, and the probability of coming positive is 4 to 6 hours. It is cleared for use in suspected sepsis patient. So we can use this in sepsis patient. So there is no intervention involved. There is no risk of any mortality. So we can all use these biomarkers to detect sepsis. So we can see this in this graph. The specificity and sensitivity of these newly diagnosed biomarkers is more than 80%. The procalcitonin is the graph is also going more than 80. Then presepsin is also 86 to 90%, and septicide is also more than around 90%. So I have told about the biomarker. So now I will tell you about the evidence, because the current practice is all evidence based. Without evidence we cannot start any treatment for a patient, and we cannot take this for our patients and diagnosis. Okay. So evidence based applications of biomarkers. So biomarkers improve the antimicrobial use. They can guide treatment decisions. Evidence supports their use in stewardship program. So how it helps us? It helps us to reduce antibiotic use. So antibiotics are now widely used in OPDs, in wards, in ICUs. So till the patient comes in ICU, the resistance is already developed. So we have to reduce the antibiotic use. So the biomarkers help us to reduce this use. Then it improves the outcomes. So once the patient is diagnosed, started with appropriate antibiotics, the outcomes also improve, and the cost also improve. So this is the study, because there are all educational, academic also people sitting here. So everybody is asking for the study. So these are the studies for the biomarkers. So Michun et al. Has given CRP versus PCT. So the sensitivity is 80% and specificity is 81%. So Ivana is also done the study for CRP. Then these are the various studies. For presepsin is Kondo et al. It has also seen the specificity and sensitivity as more than 80%. These are the more studies. These are mostly these have been done in China and Japan. Indian studies are very less, but we should know the name of the studies, and evidence is important. Now everybody is interested for presepsin. So I have taken 3 studies for this. So for a diagnostic and prognostic value. So Endo et al. It has seen that 207 ICU patient it has been studied, and it is a multi-center prospective study done by Endo et al. The presepsin showed 91.9 sensitivity versus 35% for blood cultures in distinguishing bacterial infection. So it is a multiple randomized prospective study. So we should take it as a evidence. Then for prognostic, Mason et al. Has done the study in 100 ICU patients. It is also a multicentric RCT study which has shown higher PSP on day 1 in non-survivors. So they have not shown about the mortality, but at least they have seen that in non-survivors the rate of PSP is very high. Then the prognostic value by Zhao et al. He has taken 225 ARDS patient. It is also a multicentral cohort trial. So PSP was a stronger predictor of in-hospital mortality in sepsis-related patient. So, ma'am, in our chairperson we have a pediatrician also. Pediatric ICU is also dealt with her. So she was asking regarding the pediatric study. So I have taken one study for this. So it is a BMC infectious disease 2024 study. It is showing a meta-analysis evaluating PSP for sepsis diagnosis. So sensitivity is 88% and specificity is 78%. So it has also shown as a strong potential as a biomarker, especially in neonates. So this is a pancreatic stone protein. Okay. So 3 new biomarkers: procalcitonin, presepsin, and pancreatic stone protein. So also in critically ill COVID-19, so COVID-19 has taken a very big lot of patients in our as a high mortality. So this was studied in COVID-19 patients also. So it has seen that it was higher in non-survivors versus survivors, and predictive power was also higher, outperformed the CRP and PCT as biomarkers. Now once I have dealt with the fungal biomarkers, bacterial biomarkers, I will be telling you about the fungal biomarkers. So fungal infection is not common in India, but in pancytopenic patients and in transplant ICUs, I think fungal infection is also taken over, and it has caused a high mortality. So first before dealing with the studies, I will like to help you with the what are the various biomarkers. So 1,3-beta-D glucon, this has been used in detecting fungal infections. So it is a component of fungal cell wall, and it has been diagnosed with from the blood and body fluids. So body fluids also specific if you want from ascites, from serum, from whatever culture we are doing, PCR test how we are doing, you can see from the body fluids also. It is a pan-fungal marker, may appear before mycological diagnosis and not produced by Cryptococcus and mucorales. So it can be done for the Candida species and for the Aspergillus species both. Then galactomannan. So galactomannan is a polysaccharide component of fungal cell wall. It is done from blood, BAL, CSF and peritoneal fluid. So if we are suspecting a pneumonia patient and we have done BAL for that patient, so BAL galactomannan is more specific for diagnosing pneumonia. Okay, so this everybody must be knowing. So it is really specific for Aspergillus. So if we are suspecting a Aspergillus infection, we do a BAL galactomannan for that patient. So diagnosis, follow-up and prognostication of aspergillosis is very helpful by doing a galactomannan test. Then Menin and anti-Menin tests. These are antigens and antibodies for Candida. The cacta is also known for this Candida albicans, but then the Candida other species started coming. So Menin and anti-Menin was used for Candida patients. So it is diagnosing the invasive candidiasis and useful with negative blood cultures. So if we are doing fungal cultures, fungal blood cultures, if they come negative and we are still suspecting a fungal infection, the Menin and anti-Menin is very helpful. These are the PubMed studies which are there for fungal infection. So we have evidence for this antifungal biomarkers also. So beta-D glucon is a 54% stopped early versus 2% in control and reduce the over treatment of the patient. So it has helped us to reduce the duration of therapy for the patient without increasing the mortality. I have taken each study also in the tabular form. I have taken all studies, and one study I have taken particularly of in the COVID-19 patients, the CRP and procalcitonin, which has already been implicated in this patient. So in this we had 29 ICU patients with secondary bacterial infection which means 52 patient ICU, and in this they have taken 56% with bacterial secondary bacterial infection. So whenever the COVID patient used to come and they would land up in sepsis and secondary bacterial infection, PCT has helped us to diagnose this. So you can see this analysis revealed an area under the curve as the p-value, the probability p-value is less than 0.001% for PCT. So this is very much evident with this graph. Then this study, I think now everybody is knowing, ADAPT sepsis. So for sepsis patient, biomarker guided antimicrobial stewardship, this is a theme of this study which I have taken. So it is PCT or CRP guided antimicrobial duration for patients with suspected sepsis. So for critically ill adults with suspected sepsis, does a procalcitonin guided antibiotic discontinuation prompt compared with usual care reduce the total antibiotics? So it has been proven in this ADAPT sepsis. So what is, I have taken just one slide for not causing much confusion. So how it will help us? So it is a PCT guided group. So how should we act? So if the PCT is less than 0.25 after giving 7 to 10 days of antibiotic, the protocol supports stopping antibiotics. So see, now we will be learning all gram positive infections, gram negative infections, the fungal antimicrobial CRE in the future lectures which will be coming now. But everyone will be telling about starting the antibiotics and antifungals. But there is been no stress for stopping the antibiotics. So how we will plan for stopping? So we see for the PCT value, if it is less than 0.25, protocol supports stopping antibiotics, because we have to reduce the resistance, and toxicity is also very high of antibiotics. Also, if we don't want to take a single value, we should do a trend. So once we have taken on admission the PCT value, after 10 days we will repeat the PCT. So if it falls by more than 80% from baseline, then it supports stopping antibiotics. Otherwise, protocol supports the usual care. Okay. For CRP also, if we are in the resource limited setting, the medical colleges and in the periphery where we cannot afford a PCT, so CRP is also helping. So it also it should fall more than 50% from baseline. So I have taken this study to tell you that it is a time for reappraisal and using a biomarker for sepsis before we go out of hand. Now you must be having a query that how should we use a biomarker? So at what time period we should start using the PCT, and should we give in the middle of the treatment or start of the treatment or after 10 days have passed? So this study helps us to individualize the antibiotic therapy. The physician and intensivist, they take a call based on the individual patient how to give do the PCT and individualize the antibiotic therapy. So they have shown how the biomarkers help us in the treatment response. So start of treatment, the treatment response and the dose level of the biomarker. You can see the study at home, going home, how it has helped us to take the decision. So this one slide I have taken. So there are efficacy biomarkers and toxicity biomarkers during treatment and end of treatment. So you can see how the prolonged use of antibiotic, it has caused toxicity, treatment failure and antibiotic resistance. So it is a high time that we should use a biomarker for de-escalation of the antibiotics and deciding about the dose and duration of antibiotic. So now the question comes that after we have started the antibiotic, so when to stop the antibiotic? This should be a question for everyone who are using the antibiotics, because sir has already shown about the resistance. So this slide I have taken to help you for the clinical judgment of antibiotics. So in immunocompromised patient, there are very high infection chances, but in non-immunocompromised patients, we suspected or confirmed bacterial infection without conditions during the longer antibiotic therapy, we should use a SOFA score or septic shock score. Obtain blood cultures, initiate the appropriate antibiotic therapy within 1 hour of the shock. This has been seen in the sepsis guidelines and the sepsis survival campaign. Obtain the baseline CRP before giving the antibiotics, at least CRP or PCT if pre-sepsin is not available. Then daily evaluate the patient. do a fast hug speed, we do a daily evaluation of the patient. So daily evaluation should be done for the patient. Reassess after 3 to 5 full days of antibiotic therapy. Progressive improvement is there in the patient, and absence of persistent foci of infection. So we have to see for the infection. So biomarker cannot be taken solely for the diagnosis of the infection. It should be taken as a assistance. Means for blood cultures we have to do, then we have to see for the other sources of infection. Then stop antibiotics when there are 5 full days of antibiotic. PCT should be decreased by 80 to 90%, and CRP should decrease by more than 50%. 7 full days of antibiotic therapy regardless of the biomarkers. So I have taken, I think the evidence is explained elaborately. We can do, another academics has been also covered everywhere. So everybody is now using ChatGPT also to see for the evidence. But my focus is we should decrease the length of stay. Average reduction by using a biomarker is 2.3 days per sepsis patient using biomarker protocol. Then antibiotic usage, 31% reduction in antibiotic days and decreased broad spectrum agent utilization by 42%. And cost saving is, net saving is by $2,500 per sepsis patient after accounting for biomarker using cost. You must be having a question that...
Sorry Shruti, we are short of time, so probably we'll have to skip the study part.
Just a single study we are taking in my ICU.
I'll take the comments from the chairperson, sir.
Yes. Yes, sir.
So,
This is your last slide?
Yes, sir.
Is this your last slide?
Yes, I wanted to tell about a study also, sir, which we have done in our patient. Yes, sir. Yes, sir. Yes, sir. I will just finish first. 75-year-old male patient known on case of rheumatic arthritis presented with fever and chills in our ICU. On examination, he had tachycardia, cold extremities, and BP of 90/60. Labs done showed pancytopenia, and he was taking methotrexate. So we sent the methotrexate level, and we did the bone marrow biopsy for the patient. Also the platelet was low, so we had started on given platelets and started on NORAD support. He was on NIV on day 1. On day 4 his condition deteriorated. He developed hypoxemia and we had to intubate the patient, and filgrastim was stopped for the patient. On day 1 we had done the PCT, it was more than 100, but on that day we sent repeat PCT for the patient, which came as 0.28, and we traced about the cultures of the patient. So we had started injection minocycline. We had de-escalated to tablet minocycline. So the blood culture report, it took almost 5 to 7 days to come, and it showed Tophomonas. So after 10 days of therapy, we could de-escalate the patient to tablet minocycline. Bone marrow was showing normal cellular bone marrow. I think we understood the patient. So we had used PCT for de-escalation in this patient. So we could help the patient, the extubation and improvement and decrease in the length of the stay. Okay. So I just want to conclude, we should do a teamwork for this patient. We should have a protocols for ICU. And I just want to end my presentation by this. I think now movies are very common. So Lord of Rings also says, antimicrobial need not have. I wish it need not have happened in my time. So do I, said Gandalf, and so do all we who live to see such times. But that is not for them to decide. All we have to decide is what to do with the time that is given to us. Okay, thank you.
Scott, anyone having any question, they can ask. Okay, I will start with one question. You said about PCT, reception, CRP. So, is there a mortality difference between, or we can get mortality?
See, these studies, they didn't help us to decrease the mortality, but at least they helped us to decrease the length of stay of the hospital and decrease the antibiotic days. Mortality benefits were less with the studies. Still the studies have to come to increase.
In that case, what is preferable now, since reception is already available with us?
Yes, yes.
What should I do? I should book a
So there were studies for both of them. So preception is good now for neonates.
Like when we feel like we have to send procalcitonin, so instead can we send
Yeah, preception is a very good.
what is the advantage of as always you are told like the cost is
Yeah, and preception, the comorbidities, so PCT is high in RFT, range RFT patients and range LFT patients. So if creatinine is very high, the PCT is, will become false negative higher. So preception is better than the PCT for these patients.
so currently we can all of us can take home message that preception is better than procalcitonin in current scenario.
Yes, ma'am. Yes, ma'am. For neonates, the studies has been done for neonate also. Yes, sir. Thank you, ma'am. Thank you. Thank you.
Just one thing, with pre-calcitonin and pre-sepsin, the results available with the labs, which one is the faster ones which you would get?
Procalcitonin is very fast. Procalcitonin is fast. Preception, yeah.
So basically we can start with PCT.
Actually, PCT is available in every hospitals, ma'am. Preception, maybe there must be some settings in which preception is not available. But it is
Preception may not be available in, it may be available in corporate hospital but not in.
but I have confirmed with my lab, so it is it is available in our labs.
Cost wise also,
Ma'am, just 1,000, 2,000 differences there. Sir.
thank you.
Yes, ma'am. Thank you. Yes, thank you, sir. Thank you, sir.
Thank you, Dr. Smriti Tiwari, for a informative session. I would request Dr. Archana Mhatre and Dr. Vineet Srivastava to please felicitate Dr. Smriti Tiwari.
Now we will move.
नहीं ये स्लाइड ओपन नहीं हो रहा इसमें. Moving on to the next session, infection control and antibiotic stewardship go hand in hand, especially in the ICU where the risk of resistant infection is high. This session will explore how infection control practices not only prevent the spread of infection but also support effective antibiotic stewardship by minimizing the need for unnecessary antimicrobial use.
To take us through this journey, we will request our professor and head of microbiology department, Dr. Anila Prabal ma'am. So she will give us a brief review of about the antimicrobial practices.
Thank you so much, sir. Good morning, all of you. So this topic is infection control practices, what works and what does not work. This is not a very brainstorming topic, so you can all sit back and just hear me out. Any doubt can be cleared. So we start saying that the infection control practices, these are two pillars which are very essential for a successful infection control practices to be in place. One of it is you should have an efficient antimicrobial stewardship practice along with a successful infection control practices. So if you look at this, the antimicrobial stewardship practices and the infection control practices both merge at some places. They overlap in their goals, whether it is the goals, the infrastructure or the strategies. I'm very sorry, I'm having a very bad throat. Okay, so we need to understand that what helps in making an antibiotic stewardship program efficient one. So to have an efficient program, first of all there has to be a goal towards it. So these are the goals whenever there is any organization. If you want to start with an antibiotic stewardship program, first and foremost is to have a goal for it. So the key goals of antibiotic stewardship program includes the optimization of the use of antibiotics. That is by using these 5 Ds, that is using the right drug, the right dose, duration, drug route and de-escalation policies. Then second is another goal of the ISP would be reducing the antibiotic resistance by avoiding the misuse, overuse and abuse of antimicrobials. and then this can improve the patient outcome and also reduce the healthcare cost. Now, reducing the antimicrobial resistance by avoiding overuse, misuse and abuse. I think each one of us actually contributes towards this. So, we have to ensure that we become a part of it and reduce these ones. Okay, so if these are the goals, how are we going to achieve these goals? These goals, to achieve these goals, we have to have a multidisciplinary committee. So, which of course the most important person in that committee would be a leader. It can be any head of the institute or a medical superintendent or a medical director. Then there has to be a physician who will be accountable for all of this. And there has to be a pharmacist who is a drug expertise, and there are other supporting staff which is required like clinicians, mainly preferably an ID physician but not necessarily. Then a microbiologist, an infection control nurse, hospital epidemiologist, laboratory staff and IT person. Now we are already into the AI generation, so including IT staff is very important. Many hospitals do not have an hospital epidemiologist, but they also play a very key role in auditing. So these are the goals, and these are the core elements that will help us to achieve the goals. Okay, now how does this team help us achieving these goals? Okay, so first the team has to establish a antibiotic policy. Now, making of an antibiotic policy is easier said than done actually. In our audience also there are a lot of people who have contributed to the making of the policy, and all of us know it has been quite a learning experience also. It's very tedious. So it's easier said than actually done. So it's an antibiotic policy which would tell you for what disease condition, what antibiotics is preferred, in what dose and duration, and which route of administration. That includes the OPDs, the drugs to be given for OPD cases or a critical care patient or a surgical patient, pre-surgical antibiotics, all are clearly mentioned in that. The policy would also mention the restricted use of antibiotics, the de-escalation policies and escalation policies. Hardly, I don't know how many of us are actually aware of these policies. Then these committees actually have a role in tracking the policies and guidelines which are being enlisted is being followed or not. So that is the duty of the committee. So when the committee starts tracking the antibiotic usage, it is looked upon as a mistake. It's a part of their duty that they have to track that and report. They have to audit, they have to track, they have to audit, and they have to report that. So that either the policy, antibiotic policy can be, for the next time, it can be either reframed or it can be amended. So tracking, auditing and reporting, these are very important. And these policies once made, the entire user end people, that is including all the physicians and the surgeons, needs to be educated towards it. So we have to achieve, so for an antibiotic stewardship, we set a goal, we set a team, and then this is how exactly they work. I have not enlisted all the work, these are the major work they actually do. Okay, so now just want to know that what are the challenges in its implementation. So these challenges, I don't know where to start from, but let's say start from the lack of champions. The champions are usually the physicians. Okay, from this list of members, only physicians act as a best champion. Microbiologists, nurses, nobody else can work as a best champion, not even the surgeons. The physicians are supposed to be expected to work as champions. And obviously we all know in the Indian scenario there is extremely lack of time, there is shortage of staff, there is lack of interdepartmental coordination, poor enforcement by the management. Okay, and utility of antimicrobial itself is a big question. You have an antibiotic report in hand, You are not sure whether, you should actually, you might have started patient on certain antibiotics and patient is responding, but your antibiotic report may say it is resistant. So the utility of antibiogram is a big question to many physicians actually. So maybe we should have newer diagnostic methods, which Dr. Smriti has already mentioned, some markers. So this is about the antibiotic stewardship, what works for antibiotic stewardship, what can make work, and what are the challenges in its implementations. Okay, this is very in short. This itself is a big lecture. Try to just restrict it in 25 minutes. So now these are just few points regarding how we can have a successful implementation of infection control practices. So again, we start with for the successful practices, we should again have a leadership role. It's very important, so that they can allocate the funds, the human resources and other material resources. Okay. Second is educating the healthcare workers, educating the patients, the caregivers, the bystanders, that are equally important. Okay, and once you educate them, then you have to give a refresher training. Then once you train, obviously all of us understand, if there is no assessment, we do not learn. So assessment is very important. Okay, and yes. Now once you assess, you have to monitor the performance. So you educate them. So there has to be a leader first, then you educate them, you make policies, you educate them, you assess them, and you monitor them now. So once you start monitoring, you have to give feedback, immediate prompt feedback. Now when we say feedback, it has to be a very constructive feedback. What is constructive feedback? Constructive feedback is like giving a positive feedback first, telling them what was done best by them, rather than just pointing out or criticizing them. If that is the way it is done, then you will never find any progress in their attitude. So, and fifth is, for a successful IPC program, everybody should be encouraged to follow the standard precautions. When we say standard precautions, most of us just remain stuck to the use of personal protective equipments. There is beyond that. Okay, so hand hygiene stand the first in the standard precautions, use of personal protective equipments, then environmental cleaning, sterilization, disinfection of instruments, biomedical waste management and spill management, injection and medication safety, minimizing the potential exposures, reprocessing of reusable medical equipment, and transmission-based precautions also comes, which includes airborne, droplet, and contact precaution. Each of itself is a individual lecture, so I'm just enlisted the standard precautions, not going into the details of any of these ones. Okay, and occupational health, yes, as an institute, we should ensure that we protect our healthcare workers from any transmissible diseases. So it is important to understand their immunization status. If those staff who are immunized, the institute should have a record of the immunization status. Those who are not immunized, institutes needs to get them immunized, whatever the necessary immunization required, especially the hepatitis B vaccination and to certain extent influenza vaccines. So to sum up, what exactly works for successful infection control practices, just summing up, the leadership, the education of the patient, the family, the healthcare workers. Then we are monitoring the performance, giving the feedback, and we follow the standard precautions, transmission-based precautions, and we also give importance to occupational health. What does not work or what leads to the failure of infection control programs? Now this is one of the study which tells you, okay, this was some views, okay, this was actually published as a study. These authors are basically the nurses. Okay, if you look at these points, you would know these are our voices, something which we wish to say loudly, but yes, so these are the screenshots of that. I have just taken the few points from this. So we would say that many of these were actually the direct interviews, so it is just copied in that manner. Okay, so don't take it personally. These are purely from study. Okay, so it says that the management wants to comply with the IPC measures that they themselves are not adhering to. Many of us do say this. Okay, so yes, and so they believe that the management also needs to be educated just like them. And they say that the hospital management does not care, there is nothing. When they address the issues, they are not looked upon. Okay, there is too much resistance when, yes, we also know this. At least those people who have worked towards establishing an antibiotic stewardship program and the IPC programs know there is a lot of, trust me, there is a lot of resistance. Unless and until that each of us pledge that, yes, we can make a difference, or we feel that we can make a difference, we actually cannot do anything towards it. Okay, and then many doctors say that these staff nurses do a lot of, they do not know anything. It's a blanket statement. Probably it's not right to give a blanket statement because they do a mistake. Again, so the nurses do wrong wound dressing. They do not know anything. Okay, and again, having cockroaches, there are many hospitals do not have an isolation facilities. So what I'm just trying to say with this is that we are not the only institute, or we are not the only country struggling to establish an IPC program or an antibiotic stewardship program in place. So there are other countries equally struggling with it. So in nutshell, that these are the things. So we should have, lack of knowledge and lack of positive attitude is what is stopping the infection control program, and inadequate infrastructure, poor hospital maintenance, inadequate resources, but again we have staff shortage, that is human resource, and other material resources, inadequate education and training measures, and emerging pathogens adds top of everything. And these are my references, and thank you so much. I take this opportunity to thank the organizing committee, Dr. Sandeep Agarwal sir, Dr. Nikhil Varghese sir, Dr. Smriti, and I think Dr. Indranil Rath. Thank you so much for inviting me to this talk and being part of this informative session. Thank you so much. And thanks to the chairpersons who have had the patience to listen to this. Thank you so much.
Thank you, ma'am, for your talk and sticking to the timeline.
No. Sir insisted me before the talk only.
Tremendous getting to your last slide.
Yeah, yes sir. Attitude.
Attitude and management.
Yep.
Most of the infection control practices which are being practiced or implemented, or at least implemented on paper and in corporate large hospitals where there is a large team working.
Yes.
The maximum resistance and the misuse of antibiotics happens at places where there is no coverage.
Yes sir, agreed.
Doctor-owned nursing homes, clinics, OPDs, and even pharmacies where dispense antibiotics.
Yes.
You do not have any policy in place to control things.
Yes, actually.
That's the maximum crux of the situation. Once the patient is on the corporate hospital, is already exposed to, or she is already exposed to a lot of antibiotics.
Yes, actually.
And we just damage controlling after that.
Yeah, actually the role of physicians are also left with no choice but to start off with the higher end antibiotics. But yes, please understand, have the courage to de-escalate. Please, that's I'm sure many of you are doing it, but there are few people who may fear to do that. Primarily, it is you are responsible for your patients. I know as a microbiologist, it's easier for me to tell, but please have the courage to de-escalate also, depending upon, again now, as Dr. Smriti said, there are so many parameters that can tell you whether you can step down on antibiotics. So use those parameters to scale down, de-escalate.
In our scenario also, like many patients, because of Google playing a major role, they
Yes.
diagnosis and treatment, and then they come with antibiotics already taken to the doctors.
Yes.
That also
Yes, ma'am.
a
Yes.
major role in antibiotic resistance.
Ma'am, I'm telling you myself, we are all probably very bad in antibiotic usage. When we have a disease, probably we just want to get rid of that particular scenario. Then we say, okay, next time we'll see. So we are also very bad. I would say myself very bad in complying to the antibiotics. And I don't know how many I think most of you are from Terna. Those people who do not know, just want to tell you that there is an antibiotic policy even for Terna. but just that there is a lack. Dr. Manisha Sardar, Dr. Sandeep Sir, Dr. Smriti, I think Dr. Venkatesh, all of us have worked towards making, including me, has also worked towards making the antibiotic policy. And Dr. Bhakti, there were a lot of, I'm just telling those who are present here, I just saw, so, but there are a lot of people who have worked towards antibiotic policy, making a policy, but unfortunately it is not being practiced or it is not being adhered. So unless, I know a lot of people who says, okay, this X hospital has antibiotic policy, they insist on using this policy, so we use it. Here probably, again, the leadership is very important to percolate it down to the lower cadres. So we all have to have an attitudinal change. If we think this is going to remain only a theoretical, it would always remain theoretical. Yes, ma'am.
I mean, that's what I would add to the take-home messages again that in OPDs generally, be it pediatrics, be it adult, people just come with antibiotic to shuru karna padega na.
Ah.
This is what they ask us, they pressurize us. So I think there is where we should not budge to it and we should stay whatever our clinical judgment says, we should be going according to that. So you start antibiotic when you are supposed to, as per your clinical judgment.
Yes.
And yes, as you rightly said, de-escalation is very important, which doesn't happen generally.
Generally, yes.
Antibiotics आपने दिया था तो दर्जन चालू ही है. So in OPD also and in IPD,
Yes.
it's in our hands obviously. So de-escalation is primary.
Yeah, primary. It's a courage to de-escalate because primarily for you it's a patient.
Right. As Dr. Smriti has said, this biomarkers will be of help if we use it in our.
Yes, that has to be, I think, that. Thank you so much, everyone.
Just one point. See, you're talking about the policies. I think if you have a particular policy in the hospital, it has to be adhered to, it has to be told to the surgeons and the physicians, whoever is practicing in the hospital. You cannot say that it has not been adhered to. Now,
Yes.
I am working in KDA, there is a particular protocol for all the surgeries which we do. Now, any elective surgery, we don't give more than one antibiotic dosage, that is at the time of induction. The patient doesn't get any antibiotic post-surgery at all unless there is an active infection which is shown. So this is a policy which is to be followed in the hospital. If you say that you cannot adhere to the hospital, then there's some policy, there's some problem with the policy adherence. So it has to be looked upon.
Yes, sir.
It cannot be
I
said that it is
understand.
not adhered to. It has to be from the top, it has to be from the microbiologist, it has to be from the top management itself. That has to come from there.
Yes, sir. Actually, I agree that, as I said, it has to come, we have, a team of people have made a policy, but it has not percolated down. Maybe, as I said, the leadership is very important. And as a team, we had organized a few sessions, the lectures, so that we can inform the user end. But hardly anybody attended. We had different sessions. One was for the physicians, by the physician and for the physician. One was by the surgeon for the surgeons. And one was by madam for the pediatricians. But hardly anybody attended, sir. So it's unless and until it has to.
I would recommend that it should be informed very prior to all the physicians and surgeons in our hospital. And we should be sure that they are attending it.
Yes, yeah,
Timing should be relevant.
I understand, ma'am.
Everybody in their busy practices, they do not come at home.
Yeah, that's what. So it is.
That is what we will have to arrange it for.
I'm
Yeah,
sorry to
yeah,
cut you
sure,
short,
ma'am.
but I think we are
That will-
running late for time. And probably, ma'am, this is a which is designed to create the awareness. Probably will definitely take some positive message from
Yeah.
the discussion.
So, yeah. Thank you so much.
Thank you, Dr. Anila ma'am, for the interactive session. I would request Dr. Bharat Agarwal and Dr. Manisha ma'am to please felicitate Dr. Anila ma'am. ये वाला ना एंटीबायोटिक गिव द चेयरपर्सन नाउ